Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. CME update by Mother and Child Survival Group of Pakistan. Me, Dr. Tariq, Obs Gynae Family Emergency Specialist, presently District Gynaecologist. The topic of CME today is a brief review of ovarian cancers. There are a variety of ovarian cancers, and the commonest one are these present 6,500 per year in the UK, and also the presentation is very varied, and they present with not in the gynecological setup, but they present with irritable bowel, with the constipation, with the distension, with bloating, and with other things. So in the other subspecialties they present, and then it's a high index of suspicion, and before they are raised to a very notable stage 3 and beyond, then they become obvious. So high index of suspicion is required for them. And there are also not only this epithelial 90% are epithelial origin, but there are other germ cell tumor, immature granulosa cell, dermoid, dysgerminomas, Leydig cell, granulosa cell tumors, mucinous cystadenocarcinoma, endometrioid, clear cell. So there's a lot of classification: choriocarcinoma, embryonal cell carcinoma, fibroma, thecoma, etc., etc. Then comes their genetic association and the etiology. Etiology is basically that they have, and this is basically the irritation of the germinal epithelium through their damage, and this damage can be caused by an ovulation. And ovulation increase their incidence, and suppression of ovulation decrease their incidence. And of course COCP protect them. Pregnancy has also a protective effect. Nulliparity is the most important one, which increases their incidence, and ovulatory cycles, and especially those related to treating subfertilities and polycystic ovarian disease. Then comes their genetic association as well: BRCA1, BRCA2. These are the gene involved in DNA repairs, and they are present in the affected families, and there is genetic mutation, and there is genetic transfer with these genes to the affected families. So this is very important. Plus there is also HP2 Lynch family syndrome, in which the ovarian, colorectal, and stomach endometrial cancers, they are present. They are grouped together as a cancer family syndrome. So these things should be genetic mutations, and all these BRCA1, BRCA2 should be kept in mind. Those having their sisters or mothers, any relative having breast and ovarian cancer, have the increased incidence, and those also have their anyone who is having this genetic predisposition, BRCA1, BRCA2, can have these cancer, ovarian or breast, and they have the 12% genetic predisposition. So clinical genetist referral is necessary if you find anyone who has any relative who has having one ovarian cancer or one breast cancer, or anyone who is having 3 relatives having any breast cancer or any ovarian cancer, or third, anyone who is relative having any cancer at any age. Now, how to manage these uh, BRCA mutations? These can be referred and can be dealt in a very technical way with the BSO, bilateral salpingo-oophorectomy, as most of the disease they arise from the fallopian tubes, so they must be removed as much as possible. And therefore also some occult screening tumors are also found, so for that you need to have some risk of malignancy index and CA-125 and USS. So screen them so that you are able to not only do the bilateral salpingo-oophorectomy, but also further staging laparotomy is needed for their proper management. And then some peritoneal cancer can also arise, which raise to the things from 0 to some incidence. And then anyone having breast cancer, then HRT is needed, this which also increases, so it has to be dealt with in a very tactful way. And then comes the if there is any other indication for HRT, for example for hysterectomy, for menorrhagia or dysfunction, or for any other heavy menstrual flooding, so fibroids and all these, so these can be then HRT can be given. Now their presentation, as mentioned, that they present in the other specialties mostly with their bloating, abdominal distension, increasing girth, and with the irritable bowel syndrome and other things, pressure symptoms, and pain is a late symptom. Then comes so that's why higher index of suspicion is needed in order to sort them out, and because they present at a very late stage when they becomes detected and screened out. So anyone having increasing girth, abdomen, bloating and distension, and symptoms related to irritable bowel must be sorted out. And then we have the clinical examination. You can find a pelvic mass, you can have omental mass, omental cake, ascites, pleural effusions, and lymph nodes and peritoneal mets are there. And the mass can be fixed and immobile or fixed. So accordingly then can have the investigation, baseline test, CBC, LFTs, kidney function test, and liver function test, and CT, MRI, abdomen and pelvis, and risk of malignancy index, and CA-125, the tumor marker, very important in detecting, but they are also present in other conditions as well. Then there are other markers as well, CA-19, and then there are other markers as well, CEA, but they are present in they are present as carcinoembryonic antigen in colorectal cancers. Then there are alpha fetoprotein, beta HCG, estradiol, inhibin, and estradiol. So these markers can be used, as they are found in some epithelial, in these germ cell tumors, granulosa cell tumors. Granulosa cell tumors, they produce estrogens, and while the other, they produce androgens. So they can have the signs of increased menorrhagia and this pseudo precocious puberty. Then of course then you can detect with the tumor markers and the TVSS, TVUSS, abdominal USS, and risk of malignancy index, and this marker is CA125, CT MRI, chest X-ray for pleural effusions, and for acidic, and managing now the acidic fluids and peritoneal fluids and pleural fluids. These have to tap for cytological, for biochemical, and for histological diagnosis. And as massive ascites are there, the weight loss is, history of weight loss is there, so they have to be tapped by a special cannula. And similarly the pleural effusion can be tapped out. And then we can go in for the staging of the ovarian cancers. They are present in, limited to the ovaries, limited to one ovary, limited to 1A, limited to the second ovary, and then the rupture of the capsule, and the peritoneal mets and peritoneal seedlings. And then second is the limited to pelvis, uterus and tubes, and other pelvic structures, and pelvic peritoneal washings. And then third is limited to abdomen. Then it is related to less than 2 centimeter microscopically, and then greater than 2 centimeter, and then microscopically, and less than 2 centimeter, and then greater than 2 centimeter. And then fourth is the distant one. Then obviously lymph nodes are also involved in the third stage. Now the treatment modality for the cancer of the ovary is need to have a staging laparotomy. Staging laparotomy is basically laparotomy, hysterectomy, bilateral sulfingo-oophorectomy, mental biopsy, and pleural peritoneal washings, seedlings, and lymph nodes removal, pelvic and para-aortic. Then comes obviously these malignant ovarian tumors, they need to be dealt by a surgical oncologist who is specially trained for it, and who has got the expertise and can do it in nicely, this staging laparotomy for further management. Then comes that maximum tumor should be removed, all macroscopic disease to be removed, so that then these patients who accept low grade disease 1A1, and then all the grades, especially 3C and all those, they need adjuvant chemotherapies. These adjuvant chemotherapies before surgery, and then after surgery, and then after the chemotherapy. So IDS, and these combination chemotherapy, which is given by the carboplatin agents, carboplatin, cisplatin, and also paclitaxel. Paclitaxel has some advantage that it causes alopecia, but also increases the side effect, or however some advantage, but their combination is recommended for all those. And then there is role of second look surgery, interval debulking surgery, and second look surgery. These are all needed for follow-up of these ovarian cancers. Along with the neoadjuvant chemotherapy, IDS 3 cycles before of paclitaxel and chemo, and then others are also after surgery, and then 3 cycles later on. So 6 cycles of all these chemotherapy can be given. Then we have to follow this case, and especially those with the metastasis and for the renal involvement, and for others we have to have their creatinine clearance and a CT scan, and then creatinine ratio, and then follow up is with the then 1 month, 3 monthly follow up first year, 4 monthly follow up second year, with ultrasound and with symptoms and with CA 125. So this is a very good marker, and the other marker also can be used. There are other treatment modalities which are only on clinical trials now, which are VEGF, epidermal growth factor, epidermal growth factor, bevacizumab and citrullimab and giftinib, tyrosine kinase inhibitors. So these are the one of the few new current modalities going on. Then, as I have mentioned you that about the brief review of that, these germ cell line from the whole yolk sac to the germ line, they are germ cells are there, and they migrate, and then they are differentiated into embryonal, extraembryonal, into the germ cell, into the yolk sac, from the yolk sac, and from the granulosa cell and others. So they are divided into epithelial cells, mucinous adenomas, clear cell carcinomas, and serous cell cystadenomas, and then there can be thecomas, fibromas, and then there are granulosa cell tumor, sertolinic cell tumor, and the other are also there. There are dermoid cyst, there are immature teratomas, there is embryonal cell carcinoma, there is choriocarcinoma. So we will discussing them one by one. So it's a brief review of the ovarian cancer, their management strategies, and their investigations, and high index of suspicion, and especially the genetic predisposition BRCA1, BRCA2. So we'll be discussing takeaway lesson is praise, trust, love, talk God Almighty Allah, and follow the lifestyle of Hazrat Muhammad sallallahu alaihi wasallam, our health and survival. And we must not forget our glorious past. दो नीम इनकी ठोकर से सहरा और दरिया, सिमट कर पहाड़ इनकी हैबत से राई. And subhanallah wa bihamdihi subhanallahil azim, la ilaha illallah muhammadur rasulullah, and Allahumma zikrak shukrak wa husna ibadatak, and always ask from God Almighty Allah, who says हम तो माइल बा करम ही को साइल ही नहीं, राह किसे दिखलाएं राह मंजिल नहीं. So with this we come to the brief review and of a brief review of an ovarian cancer's presentations. So for the next, goodbye, best wishes, wama alayna illa al balagh.